I'll be talking to you about the head and neck trauma. The objectives of my presentation today is to know the first aid management in emergent head and neck trauma, how to properly assess the patient, and what are appropriate investigations you should ask for, and what are the alarming signs for specialist consultations. Although head and neck trauma may be uncommon, it may be representing about 10% of presentation in the emergency room, but it may be a knocking trauma to the patient. Because of the complex anatomy of the head and neck and important structures in this area, we have, of course, injury may affect the soft tissues only. However, it may affect the other aerodigestive tract, vascular injuries, bone fractures involving the sinonasal and orbit, skull-based temporal bone fractures, or neurological affection of the spinal cord injury or cranial nerves affection. Most of the causes of head and neck injuries are blunt trauma. About 85% of cases will be a blunt trauma, whether a motor vehicle accident, sport injuries, bicycles, falling, hanging, strangulation injuries. Gunshots or stab wounds accounts for about 15% of cases. When you receive to assess this patient in emergency, you should follow the advanced life support system and look for multiple injuries or multi-traumatized patients. If you suspect a spine injury, you should immobilize the head, put the head in, immobilize it by sandbags, or you can use a collar, neck collar. Avoid extension of the neck to avoid transection of the spinal cord. We have to maintain the airway, avoid the head extension, and we can use the jaw thrust by 3 fingers and pulling the mandible forward to open the airway. Of course, we need to suction vomitous blood in the oral cavity. If you suspect injury to the airway, laryngotracheal airway injury, we should better to avoid intubation because it may increase this injury. And it's better to go for a tracheotomy or cricothyrotomy in emergencies. Vascular injury, in this area we have a serious concern of air embolism. If there is a jugular vein injury, we have to take care of that by compression, putting the patient in Trendelenburg position or left decubitus position, with no problem in moving his neck. As an emergency, we may need a tracheotomy to open the airway. The surgical tracheotomy is better be done in the theater. We need special equipment, opening a transverse incision or a vertical incision, retracting the strap muscles. We may cut or retract the thyroid isthmus, and then open the trachea between the second and third trachea rings, doing either a flap, inferiorly placed flap, or just a vertical incision, and we put a tracheotomy tube. A percutaneous tracheotomy set may be available in the OR, in the emergency room. You can use it, but actually it needs a patient being intubated in the ICU. But in real emergency situation, we may need to revert to the cricothyrotomy because there's no extension needed, and it's a very simple procedure. We should know, or we should be practicing or knowing about it. In a simple way, you just first of all, you have to palpate the airway, the larynx, immobilize it by your left hand, and with a scalpel, just make an incision with a vertical or a horizontal incision between the thyroid and the cricoid. Okay, and then we make a transverse incision in this membrane and put a tube, 5 to 6 tube. In a real emergency, you can use just a wide pore cannula. You can put it, but provided that you have a high pressure ventilation system to push air inside. Sometimes also, if you have available kit for cricothyrotomy, it will be helpful. The blunt neck trauma is the major encounter we face the patients. We have a lot of protective mechanisms. The mandible is the main protective mechanism, and reflex flexion of the head on the chest. This protects our neck. In situations, some situations force or remove this mandible protection and putting our neck and airway to the risk. This is during a car accident, improper use of seat belts. This is an old seat system. We should be using the one across the shoulders, and the airbags prevent this injury. Sport injuries, strangulation injuries, or clothesline injuries. Sometimes a patient riding a bicycle and is hit by the clothesline on his neck. A very common injury is long scarf injury by motorcycles and or machines. This long scarf become entrapped in it, and it causes a strangulation injury for the patient. When we suspect laryngotracheal injury we find a surgical emphysema in the neck, blunting of laryngeal contour, developing stridor and dyspnea, hemoptysis. This happens because of the shearing forces between the thyroid cartilage, hyoid bone, to this spinal cord, and this causes these injuries, which might be just a simple hyoid fracture, thyroid fracture, cricoid fracture, or a complete cricotracheal separation. This is a CT, in this case, for assessment we need a CT scan. There is a fracture in the thyroid cartilage, and there is a surgical emphysema all over the neck. And this is a fiber optic evaluation showing the fractured laryngeal contour. If we suspect laryngeal trauma, first of all, we should assess the airway. If the airway is stable, we have time to do a flexible endoscopy or do a CT scan and for better assessment. But if it's an emergent airway problem, better to avoid intubation and proceed to tracheotomy. Cricothyrotomy, even maybe hazardous to such patients, may increase the laryngeal injury, but sometimes it may be a life-saving. So if you are not able to do a tracheotomy, formal tracheotomy, do a cricothyrotomy. According to the severity of injury, we either observe and giving steroids and proton pump inhibitors with humidifications, or we proceed to tracheotomy and direct laryngoscopy and repair, whether by plates and screws or just wiring, and internal stenting. Also, in about 25% of these patients with laryngotracheal injuries, 25% of them will have a pharyngoesophageal injury. We suspect with developing dysphagia, hematemesis, or presence of saliva in the wound. First of all, avoid anything oral. CT here in this patient will find air in the posterior compartment of the neck related to the esophagus, air in a plain X-ray just in the prevertebral space. We may do a fiber optic endoscopy for assessment of this tear, or doing a gastrography swallow. Our fear of this injury actually is complicating mediastinitis. If the patient is passed unnoticed and he starts to take oral fluids or foods, and he passes into mediastinitis. Penetrating neck injury, either a stab, it's actually a low force causing soft tissue injury and vascular damage, and mainly venous damage, or gunshots with a high energy and passing through the tissues and extreme heat and necrosis, so there is an extensive damage for the gunshots. The Classification of the neck zones into neck zone 1, this is from the thoracic inlet to cricoid cartilage, zone 2 from cricoid cartilage to the angle of the mandible, and then to the skull base is zone 3. This classification is good. Zone 2 is safer for surgeons to explore. Zone 1 and 3 is very difficult, so we may observe more. But this classification now with the advent of more CT angiography is recommended more and more for assessment of vascular injuries of these patients. Professor Sabur has covered the vascular injuries and what are the major signs and minor signs of vascular injuries. We should be aware of that for the immediate carotid arteries. For penetrating neck injuries, unstable, we may do immediately for intervention, or if it's stable, we have time for doing CT angiography or CT, and so for assessment and further management. For other trauma in the head and neck, we'll discuss a sinonasal trauma in a minor format, just a minor trauma to the nose of a child. We present this septal hematoma, severe nose blockage, and if it's not drained, this will cause cartilage necrosis. So it needs to be, you simply can detect it by just elevating the tip of the nose and looking inside. Nasal bone fractures with closed reduction in early days or later on, but we have a comminuting fractures of the nasal-orbito-ethmoid, frontal, maxillary fractures might need intervention with open reduction and internal fixations. The major problem that we may face in this sinonasal trauma is affecting the orbit with developing orbital hematoma. A retroorbital hematoma actually in this area pushing the eye globe, and this causes a compression to the optic nerve, which is very vulnerable blood supply and causing rapid deterioration of vision. An emergency, you should do a lateral canthotomy and lysing the lateral canthal ligament. Epistaxis, it should be controlled by anterior nasal packing with the Vaseline gauze, but now we are usually using the Miricel or the balloons, or sometimes using the posterior nasal packs. Temporal bone fractures, we should be aware of just a simple hematoma, maybe harboring a comminuted fracture, and there is a risk also for the carotid artery in this area. And we should look for the facial nerve injuries. Immediate facial nerve injuries following trauma require immediate surgical decompression. CSF leaks, we should be aware of the halo sign. If we find from the bleeding from nose or from ear and around the gauze, around the blood clot, we will find a clear fluid, a halo sign. This is suspicious of a CSF leak. Usually passing conservative, avoiding nothing local, and giving gensemicetting and antibiotics crossing the blood-brain barrier, acetazolamide for decreasing the CSF pressure. And if it persists, we should go for repair. So early suspicion and prompt management of patients with trauma involving head and neck is vital for the good functional outcome. Following the advanced life support, securing the airway, controlling the vascular damage, and sometimes we need exploration and repair. These are further readings for according these subjects. And finally, I hope for our country to get through this situation we are in. And for any questions, I'm ready. Thank you very much.